Megaloblastic anemia in children. In this topic, I will discuss about the definition of megaloblastic anemia in children, and I will discuss the two most common causes of megaloblastic anemia in children: folate deficiency and B12 deficiency. Megaloblastic anemia describes a group of disorders that are caused by impaired DNA synthesis. Red blood cells are larger than normal at every developmental stage, and there is maturational asynchrony between the nucleus and cytoplasm of the erythrocytes. There is often an associated thrombocytopenia and leukopenia in addition to anemia. The peripheral blood smear is notable for large, often oval RBC with increased mean corpuscular volume, or macro-ovalocyte. Neutrophils are characteristically hypersegmented, with many having greater than 5 lobes. Most cases of childhood megaloblastic anemia result from deficiency of two vitamins, which are essential for DNA synthesis. Those are folic acid and B12 or cobalamin. Folic acid is essential for DNA replication and cellular proliferation. Like other mammals, humans cannot synthesize folate, and they depend on dietary sources including green vegetables, fruits, and animal organs. Folates are heat labile and water soluble. Consequently, boiling or heating folate sources leads to decreased amount of vitamin or deficiency of folate. Megaloblastic anemia, as a consequence of folate deficiency, has its peak incidence at 4 to 7 months of age, somewhat earlier than iron deficiency anemia. Although both conditions might present concomitantly in infants with poor nutrition. Body stores of folate are limited. Deficiency can develop quickly in malnourished individuals. On a folate-free diet, megaloblastic anemia will occur after 2 to 3 months. When we see common causes of folate deficiency in children, the first one is inadequate nutrition, which can be from poor diet, poor food preparation method, or exclusive meat feeding of goat milk, which is deficient in folate. The other is defect in absorption. This can be from inflammatory bowel disease, celiac disease of upper small intestine, or any other issue. Increased requirement or losses might occur during pregnancy and lactation, in premature babies, in chronic hemolytic anemia, in hyperthyroidism, dialysis, and also other disorders such as Nahan syndrome. The other cause can be disorder of transport, which can be from cerebral folate deficiency, which can be genetic or acquired. Disorder of cerebral metabolism, such as drugs that inhibit folate metabolism. Those includes methotrexate, pyrimethamine, cotrimoxazole, valproic acid, and other inherited defects can cause deficiency in folate. Clinical manifestation is a feature of anemia. General signs and symptoms of anemia such as shortness of breathing and tachycardia, lack of energy, dizziness, vertigo, especially when standing, headache, and irritability. Symptoms more common in folate deficiency anemia as compared to other causes of anemia include irritability, chronic diarrhea, poor weight gain, hemorrhage from thrombocytopenia may also occur in advanced cases. When we investigate such patients, on CBC we will see low hemoglobin and hematocrit, high MCV and red cell distribution with occasionally neutropenia and thrombocytopenia may present, so pancytopenia can occur. The retic count is low, and the peripheral morphology shows nucleated RBC with large and hypersegmented neutrophils, majority of them more than 5 segments. Low serum and RBC folic acid levels, and high serum LDH, which is a marker of ineffective erythropoiesis. The normal serum folic acid levels are from 5 to 20 nanogram per ml. With deficiency, levels are less than 3. Levels of RBC folate are better indicator of chronic deficiency. After folate deficiency is diagnosed, folic acid orally 0.5 to 1 mg per day to be continued for 3 to 4 weeks until a definite hematologic response has occurred should be given. Maintenance therapy is multivitamin containing 0.2 mg of folate is adequate. If the specific diagnosis is in depth, smaller dose of folate, such as 0.1 mg per day, may be used for 1 week as a diagnostic test, because hematologic response can be expected within 72 hours. Dose of folate more than 0.1 mg can correct the anemia of vitamin B12 deficiency, but might aggravate any associated neurologic abnormalities. The next is vitamin B12 or cobalamin deficiency. Vitamin B12 is a generic term encompassing all biologically active cobalamins, which is a water-soluble vitamin. Methylcobalamin and adenosylcobalamin are the metabolically active derivatives serving as cofactors in two essential metabolic reactions: in methylation of homocysteine to methionine and the conversion of methylmalonyl coenzyme A to succinyl-CoA. The product and the byproduct of this enzymatic reaction are critical to RNA, DNA, and the protein synthesis. Cobalamin is synthesized exclusively by microorganisms, and humans must rely on dietary source, animal products including meat, eggs, fish, and milk for their needs. Unlike folate, older children and adults have sufficient vitamin B12 store to last 3 to 5 years. In young infants born to mothers with low vitamin B12 stores, clinical signs of cobalamin deficiency can become apparent in the first 6 to 18 months of life. Vitamin B12 deficiency can result from inadequate dietary intake of cobalamin, for example, as in the case of breast milk of B12 deficient mother. It can be from lack of intrinsic factor, it can be from pancreatic insufficiency, it can be from removal of terminal ileum, gastric surgery or medications that impair gastric acid secretion, and it can also be from impaired intestinal absorption of intrinsic factor, which is bound to cobalamin. Absence of B12 transport protein or transcobalamin deficiency can also cause vitamin B12 deficiency. Clinical manifestations include non-specific manifestations such as weakness, lethargy, feeding difficult, failure to thrive, and irritability. Other common findings are pallor, glossitis, vomiting, diarrhea, and icterus. Neurologic symptoms can include paresthesia, sensory deficiency, hypotonia, seizure, developmental delay or degradation, and the neuropsychiatric changes. Neurologic problems from B12 deficiency might occur in the absence of any hematologic abnormalities. The hematologic manifestation of folate and cobalamin deficiency are identical: macrocytic with prominent macroovalocytes of RBC. The neutrophils are large and hypersegmented, and neutropenia and thrombocytopenia can occur in both. Serum vitamin B12 levels are low in the case of cobalamin deficiency. Serum concentration of methylmalonic acid and homocysteine are usually elevated, but in the case of folate, only methylmalonic acids are elevated. Serum lactate dehydrogenase activity is markedly increased, which is a reflection of ineffective erythropoiesis. The cause of B12 deficiency should ultimately dictate treatment dosage and the duration of therapy. If it is uncorrectable, or if the underlying cause is uncorrectable, such as intrinsic factor deficiency, the treatment is lifelong. Otherwise, the treatment is only for 1 to 2 months. Cyanocobalamin, 1000 microgram IM daily for 5 to 7 days, followed by 100 microgram per week for a month is enough if it is correctable, if the cause is reversible. But if it is from malabsorptive causes such as intrinsic factor deficiency, B12 deficiency, monthly maintenance dose is given lifetime. The physiologic requirement for B12 is around 1 to 3 microgram per day. Thank you for watching.